So I'll be speaking in brief about rheumatological diseases complicating pregnancy. I'll try to keep it simple, and I'll not go into too much of technical details. What I'll focus is more on management aspects, how we manage these cases when they come across to us from the point of view of primary and obstetrician, and from my perspective also. So just a brief slide. So pregnancy is an immunotolerant state. Basically, there are certain changes, physiological changes that need to happen in the mother so that the maternal immune system does not reject the fetus as a foreign body. So that is what happens here, in which there is something called a Th1 immune response shifts to a Th2 immune response, which makes the mother more accepting of the fetus, reduces the pro-inflammatory state, and creates a non-aggressive state. So that is what generally happens in pregnancy. However, life is not so simple. There are a few conditions in the immune system in which it can go haywire, and especially in pregnancy. So I'll be touching on these commonly encountered issues that we see as a common rheumatological and from an obstetric point of view. So the first one which I'll speak about is what we call as congenital heart block, or an anti-Rho positive mother who is planning or becoming pregnant. Then I'll talk about drugs in pregnancy from the point of view of the anti-rheumatic drugs. I'll also be speaking about how SLE, the most common autoimmune disease that we see complicating pregnancy, how we deal with it. And the last one is, again, recurrent pregnancy losses and the role of antiphospholipid antibodies in such a patient. So I'll just begin with a case. So this is a patient that we had 5 months back. So we had a 31-year-old lady who presented to us at 7 weeks of gestation. She had a past history of 2 spontaneous first trimester abortions. There was no maternal history suggestive of any form of connective tissue disorder. So the normal history that we ask for is things like joint pain, skin rash, Raynaud's phenomenon, excessive hair fall. All these things, she had absolutely no symptoms. She just had 2 unexplained first trimester abortions. So we worked up this lady once she presented to us, and what we found is that the ANA was 3+ in a nuclear speckle pattern. We did an APLA profile considering the 2 spontaneous first trimester abortions, and what we found was the IgM beta-2 glycoprotein 1 was weakly positive and the rest were negative. Now, on further characterizing it, what we found that the anti-Rho was high titer positive. So this is around 129. Anything over 40 to 50 is positive, depends on the labs, but anything over 80 is considered as a high titer positive. Subsequently, we started her on hydroxychloroquine, low-dose aspirin, as well as a prophylactic dose of enoxaparin. Now, the hydroxychloroquine was primarily started from the point of view of she being anti-Rho positive. The aspirin and enoxaparin were given because she had 2 spontaneous first trimester abortions with a weak positive APLA. So, to cover both of these things, we started her on this regimen. Unfortunately, a couple of months, 3 months down the line, at 18 weeks on a routine follow-up, we found that the fetus had complete heart block, along with some degree of fetal hydrops. So there was some polyserositis, pericardial effusions in the fetus. At this point, what we did is we explained to the family about the prognosis of this. We gave the child IV immunoglobulins, 1 gram per kg over 2 days. We gave a short course of dexamethasone. The hydroxychloroquine and the enoxaparin was continued. On regular follow-up visits, what we found was the hydrops part definitely improved. However, the complete heart block was persistent. There was no improvement in the PR interval. We continued with expected management with a very guarded prognosis explained to the family members. The infant was delivered at 34 weeks. However, owing to complications of the underlying heart block, as well as a prolonged ICU stay relating to other complications of premature delivery, the child unfortunately succumbed. So this is what is the scenario of what we call as neonatal lupus, or a complete heart block. So this is seen in up to 2% of patients, mothers who have anti-SSA antibodies. And this risk increases by 10 times, up to 20%, if the mother has had a history of a previous complete heart block. Typically, this phenomenon of this heart block, this transplacental transfer of these antibodies occurs between a period of 16 to 28 weeks. Before this, the risk is not much. Beyond this, the risk is not much. This is the critical period in which the problems can arise. Patients need not necessarily have any features of connective tissue disease as such, and they may be absolutely asymptomatic, like we had in this particular patient, in which he had absolutely no symptoms, just antibody positivity causing this whole issue. And typically in such a patient, we will not label them as a Sjogren syndrome just based on antibodies. We'll just call them as she has antibodies positive with this. Unless patient has clinical features, we'll not typically label them with a diagnosis of a connective tissue disorder. Now, how do we treat this patient? So this is a challenge most of the time. So if we classify it as into first degree, second degree, or third degree heart block in the fetus. So in utero, if we detect a first degree heart block, so again, everything is a shared decision making, nothing is foolproof. We explain to the patient the risks and the benefits, and in conjunction with the fetal medicine specialist, with the obstetrician and the pediatric pediatric cardiologist if available, we take a call. So first degree heart block is generally treated with a short course of steroid. So dexamethasone is preferred because it crosses the placenta. We give 4 mg once a day for 7 days, and we repeat the Doppler after 7 days. Suppose we find that the heart block has progressed to a complete heart block and there is no extranodal disease. So extranodal disease includes things like the myocardium getting affected or certain things like that. So if there is no extranodal disease and it has progressed, then there is no role of continuing the dexamethasone, and we should be stopping it. If the first degree heart block reverts to a normal sinus rhythm, then probably it means that it is working, and we should continue it for at least 26 to 28 weeks, and then probably thereafter stop, because the risk period is until that time. Second degree heart block, definitely there is a role of dexamethasone again. Again, the dose is typically, we give it for 7 to 10 days at 4 mg once a day, and then see about what is happening. Again, like in first degree heart block, if it progresses to a complete heart block and there is no extranodal disease, we should be stopping the dexamethasone. It is unlikely to be of help. If the second degree heart block downstages to a first degree heart block, or a normal sinus rhythm, then again we will continue the dexamethasone till week 26, and subsequently can taper with a close monitoring. If it persists at second degree heart block, then that is where there is a gray area. Probably we can continue DEXA, or we can continue give a trial of IVIG at a dose of 1 gram per kg, if not already given before. So this is how we manage a second degree heart block.